we think about the nuances and the stratifications and how we classify specialty, I do think that Laura did a really nice job of describing it. It's high cost and then something else. Is that something else that needs to be stabby? Is that something else needs to be in the fridge? Like, what is that something else? No one knows. That's what makes it so special, literally and figuratively.
It's all one team, because at the end of the day, the prescribers want their patients to get their meds too. We all have the same goal. Let's get our patients their meds in a timely manner and hopefully, help whatever underlying condition they're struggling with.
Welcome to Medication Talk, the official podcast of TRC Healthcare, home of Pharmacist Letter, Prescriber Insights, RX Advanced, and the most trusted clinical resources. On today's episode, listen in as our expert panel discusses the challenges and solutions for ensuring access to specialty medications, including how social determinants of health play a role and strategies to overcome barriers caused by these factors. Our panel for this conversation includes Dr. Laura Sosinski, a pharmacy manager at Walgreens Specialty Pharmacy, Dr. Patricia Romero, a certified specialty pharmacist with Walmart Specialty Pharmacy, Rachel Popp, who is with us today to provide her perspective as a patient who has been treated with specialty medications, Dr. Jake Galdo, a pharmacist and managing network facilitator with CPESN Health Equity, and Meredy Ayers, an advanced certified pharmacy technician and development specialist at Bremo Pharmacy. This podcast is an excerpt from one of TRC's monthly live CE webinars. Each month, experts and frontline providers discuss and debate challenges in practice, evidence-based practice recommendations, and other topics relevant to our subscribers. The full webinar originally aired on June 20th, 2024.
And now, the CE information.
This podcast episode offers continuing education credit for pharmacists, pharmacy technicians, physicians, and nurses. Please log into your Pharmacist Letter, Pharmacy Technician's Letter, or Prescriber Insights account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Now, let's join TRC editor, Dr. Flora Harp, and start our discussion.
I thought I'd kick us off by reviewing a patient case and getting our panelists' thoughts. So let's consider the scenario. A patient has severe eczema, which is an inflammatory condition that often results in rashes, itchy skin, and dry skin. And for this particular patient, their eczema was so severe that it kept them up all night itching, and they had to deal with rashes from head to toe. The patient was prescribed an injectable medication that was considered to be a specialty med by their payer. The payer required a prior authorization, or a PA, so the pharmacy and the provider worked together to submit this. The PA was approved, and the patient experienced life-changing improvements with this medication that for them was highly effective. Things were going great until a year goes by and the prior authorization expires. Upon resubmission of the paperwork required, the PA was rejected because Meredy no longer met the criteria. I want to turn things over to Patricia and get your thoughts on this. Is this a scenario that you've ever experienced? And if so, how is it handled? Or how would you approach the scenario if it were to occur in the future?
Thanks, Laura. Yeah, so unfortunately, the situation does happen. PAs are required to be renewed, most often on an annual basis. So it is important to make sure that patient is maintaining follow-up with their prescriber to ensure that their progress on treatment is being documented appropriately and thoroughly. That way, when you go to resubmit for PA, that clinical information is on there and they can review it. You also want to make sure that you are keeping track of what's been tried and failed in the past and how this medication is improving the patient's symptoms currently. Another thing that's good to have documented is when the PA is going to expire. So that way the PAs can be worked on proactively as opposed to waiting until it expires to then work on them. And also if patient has a new insurance plan, a new PA would probably be required as well. So that's something to keep in mind.
Great points. I'm going to see Laura, do you have any other impressions about the case? Any thoughts?
Yeah, other things to kind of add and think about. Obviously, the patient is doing better because they're on this medication. So making sure when we resubmit a PA that you have that clinical documentation that Dr. Romero was talking about included. So don't just check all the boxes, make sure you're including a clinic note. Unfortunately, some insurance companies will still decide to deny the PA. In those cases, we may have to go down the appeals route, which is not fun, but that may be the route we have to go through with insurance. Maybe the insurance formulary changed and we have to change to a different injectable. Maybe we have to change to a biosimilar. So there's other unfortunate options out there. So it's going to be almost a game to play to see what the insurance wants and prefers sometimes.
And so, Rachel, to hear your thoughts on the case and just from the patient perspective, all of those things that are happening behind the scenes that you don't necessarily get much exposure to. Kind of what are your thoughts on that?
Thank you, Flora. Unfortunately, I have been on the receiving end as the patient. Whenever I was going through the cancer treatments, we went through the route of, okay, we obtained a PA, we're going to start my treatments on the medication. It worked, it was amazing. But some plans, apparently, and I didn't know this, their PAs only last for up to 84 days, 90 days. So once the treatment would be completed, I'd be doing great. I'd go in for my next appointment only to find out the PA had been denied. So my treatment would then get delayed. And I personally had no idea what was going on in the background. I didn't know what was going on the pharmacy side or my plan side. I wound up going through probably 4 different treatments just because the prior authorizations kept getting denied until about like 7 months down the road, I got put back on the same medication I was on in the first place. And it was extremely confusing and honestly very defeating dealing with it.
For sure. I can't even imagine. And, we're going to get into more of the details about these challenges and hopefully strategies to overcome them. But I do want to shift the focus over to the basics. What even is a specialty medication and how do they compare to traditional medications? And Laura, I was hoping maybe you can help clarify that for our audience.
Yeah, so generally speaking, to keep it as black and white as you can, I like to think of specialty medicines as anything that's usually high dollar that is treating some kind of complex chronic condition. So in this case, in the patient case, we had the eczema. That's a chronic condition and it was pretty complex. The patient couldn't sleep at night and injectables tend to be high dollar. So trying to keep it as simple as possible, high cost, complex, and chronic.
Great, Laura, thanks. Yeah, it is confusing because different entities define it differently. And so that is a great way to think of it. Can you provide some examples of specific specialty medications that you're commonly dispensing or dealing with and the conditions that they treat?
Yeah, so currently other things would include a lot of cancer meds. Those tend to be oral ones. So a lot of times people automatically think injectables only, but there are a lot of oral meds. Currently, a newer, fancier med for Demodex blepharitis, which is actually an eye drop. That's been a specialty med that we've been seeing a lot of asthma, COPD, when we think of sickle cell, autoimmune disorders, multiple sclerosis. The conditions can just vary.
Yeah, and it's definitely, again, back to the challenge of everybody defines it differently. Meredy, I'm wondering if you can address this question that I have here, which is, how do you even find out if a medication is considered specialty if you're filling it at a local community pharmacy?
The simplest way that we find it at the community pharmacy is the simple rejection from the pharmacy benefit manager. The patient can find out prior to coming to us utilizing their formulary or the preferred drug list. The general public doesn't realize that. So of course, when we run a claim, we will see it at the time of service.
Yeah, great. And I don't know if you're seeing more specialty medications in the community pharmacy. I know it's one of the fastest growing pharmaceuticals with around 80% of new drugs that come to market being specialty. However, despite the fact that they make up the majority of new FDA approvals, they still account for just 3% of prescriptions, but they still account for over half of the drug spend in the US. And so that's why there's a lot of focus on these medications. The average annual cost of one specialty medication used chronically is over $80,000 compared to $6,000 for a brand name traditional medication. And so I was wondering if we can talk next about some of the main pathways for patients to access specialty medications. And Patricia, hoping you can elaborate on that a little bit more.
I feel like one of the easiest way to get the prescription sent in is taking advantage of the manufacturer hubs. A lot of the specialty meds do have a manufacturer hub that they can fill out that referral form, send it into the hub, and they'll start the benefits investigation, see, depending on the patient's insurance plan, who their preferred specialty pharmacy is. If the patient does need copay assistance, they can indicate that on that form to start getting that process in place. I think it's the fastest way to get patient on therapy.
Rachel, I'm wondering if you can share your own experiences in getting prescriptions for specialty medications filled in different places.
Thank you, Flora. Actually, initially, whenever I got prescribed the medications, I was under the impression, and through my prescriber as well, that they were just normal medications, grab them from the pharmacy, bring them to the center to get the infusion done. And nah, that wasn't the case at all. I had to be routed from the retail pharmacy that I went to a third-party pharmacy. They got routed to another specialty pharmacy that my insurance wound up not accepting. And then I got routed again. At this point, it's 2 months down the line. So it's a little confusing getting implemented into it. But I think Patricia has a good point. Going through the manufacturer was the easiest way to do it and the most informative way too, because they have a built-in support system that helped me tremendously on my journey through this.
Very interesting. Yeah. So if a payer classifies a medication as specialty or even a manufacturer, I guess, does this always mean that it has to be filled at a specialty pharmacy? Patricia, is that something you can answer?
Yeah, so when you get that rejection, a lot of times I see it as must fill at specialty. Most of the times it does need to be filled at specialty. There can be sometimes an insurance may allow like a grace fill to fill at retail or community pharmacy. I have seen that as well. It's going to depend on whether the medication can actually be ordered, because a lot of times they can be limited distribution drugs. So the community pharmacy may not have access to it. And then after that one time or grace fill, most likely they're going to have to go to a specialty pharmacy at that point.
All right.
May I jump in? I've been quiet, but I'm itching to jump in if that's okay.
Oh, go ahead.
So I think the nuance that we need to highlight here is that it is very, very regional. There are state differences. So I'm in the state of Alabama. There's a big payer here down the street. And that payer may designate drug A to be specialty. So then I'm in Alabama and I cannot dispense drug A, but Meredy in Virginia can. And so when we think about the nuances and the stratifications and how we classify specialty, I do think that Laura did a really nice job of describing it. It's high cost and then something else. Is that something else that needs to be stabby? Is that something else needs to be in the fridge? Like, what is that something else? No one knows. That's what makes it so special, literally and figuratively. And so then that's like the construct of what the drug is. And then the distribution is this financial model that is going to involve medical benefits, because it is a medical benefit drug, or is it a special or a pharmacy benefit drug? It involves the PBM. How are they intertwined with each other? Is it a vertically integrated company where they just pass it from Peter to Paul, or are they separate entities on the bid contract? Again, these are all the different nuances. So when we think about this construct of what is specialty, it really does fall within the idea of, do I have access to buy it? That's the limited distribution phrase that you've heard us say. Or can I actually even sell it to the person in front of me? So with this drug A example, I might have access to it in Alabama, but I can't sell it because my primary insurance designates it as specialty. Or it's drug B, where I could sell it to the person in front of me, but my pharmacy wholesale contract says I cannot buy it. It's only going to go to pharmacy A or pharmacy B.
Yeah, great points, Jake. And as you were talking, I was thinking to myself, how do we explain that to a patient, though? How do you explain to a patient that they have a prescription for a specialty medication and that it has to be filled elsewhere? Patricia or Rachel, if you want to jump in on how you think that could be best communicated to a patient.
when they do get a specialty medication, we introduce them to the specialty concept of, okay, now you're going to be getting this medication. We do have to talk to you, every month or however often it's prescribed for you to take it. It's going to have to be shipped to you. It's not something that you can just run down the street and get it. It does need to be shipped. It's going to come in a specialized container. It's got to be kept at a certain temperature. And we make sure that the patient understands all the requirements that go with having that specialty medication.
And Laura, I just want to give you the opportunity if you wanted to chime in on this.
Yeah, I kind of wanted to add to a couple of things Dr. Romero was saying. But basically, the other thing is it's really important that when we're trying to explain to patients what a specialty med is and how we're going to help them through this journey, it's important that we use like patient-friendly terms. So I try my best, as well as trying to coach my staff the best, not to use terms like limited distribution, because your normal type of person out there is not going to know what that means. So trying to phrase it in ways like, well, the company that makes this drug only allows certain pharmacies to have it. So that's why you're getting called from me in central Indiana instead of your local pharmacy in southern Indiana, and so on. So trying to make it in friendly terms, because patients can get very confused and can get very mad when they have someone calling them from a different state, calling them from a different part of the state, and are completely confused. So trying to use friendly terms that they can understand.
I just wanted to see if we could expand on what can prescribers and community pharmacy staff do to collaborate, and vice versa with specialty pharmacy staff. And so I was wondering, Patricia, if you maybe want to take this first, and then Laura, I'll pass it over to you.
Yeah, I mean, one important thing that I think can be started on is the benefits investigation, because that's going to really determine where everything is going to go and what can actually be prescribed to a patient, depending on their formulary. So just doing a quick benefits investigation, starting at the prescriber's office with, if they've got a PA specialist or someone that handles PA, calling up the patient's insurance plan and seeing, okay, I want to prescribe this drug to my patient. What is the formulary? What does the patient have to meet in order to get this drug? Is there a PA required? What does that look like? Are they going to have to try and fail a different medication first? Getting all that up front would save time to getting patient on their medication and help prevent some of that delay.
That's a great tip. Laura, do you have anything to add?
Yeah, so I think another thing that's huge is remembering that we're all part of the healthcare team. So how can we close a gap? How can we make relationships with the providers in the offices that we know are prescribing these medications? So is that, finding out the extension that the nurse who does the PAs at this office, knowing their name and them knowing your name. We have a lot of those scenarios at my pharmacy where we know this office, the nurse is this name at this extension. And they know like this pharmacist works on these meds, or if they have this issue, they need to ask this person. So trying to make relationships, whether that's, going to the doctor's office, talking to them, whether that's doing community events so patients see you and know. Right now, the pharmacy I am in does a lot with the LGBTQ plus community. So we do our best to go to Pride events and do all of that. So showing people like, hey, we are here. How can we help you? How can we bridge your gaps? So one, word of mouth, but also knowing it's all one team. Because at the end of the day, the prescribers want their patients to get their meds too. We all have the same goal. Let's get our patients their meds in a timely manner and hopefully, help whatever underlying condition they're struggling with.
What are some other common barriers, Laura, I'll direct this to you, that you see that your patients are encountering when trying to get access to specialty medications that we might not have already talked about?
Do you have all day? Is the real question. There are a lot. I actually teach social determinants of health at a college of pharmacy, so I could talk to you all day, but there's many. So whether that's one, the insurance access. So do they have insurance? If they do have insurance, how much does it cover? How much money do they make? Do they qualify for grants? Are there grants open? So one big thing is just cost, what's available to help the cost. Cost is huge. Next would be, I would say, where are they going to get the med? Is it available to be shipped? So in Indiana, we have lots of areas that are rural healthcare. I have tried to FedEx meds to patients multiple times. FedEx can't get there. FedEx doesn't know where the address is. Constant barrier, can't even find where a patient lives. Getting to your provider in rural areas, how are you going to get to your provider for follow-ups so that you don't have that break? So you can get your PA renewed. That's a huge barrier. Other barriers would be languages. We have lots of patients who speak different languages. I speak decent Spanish that I can get through most of our Spanish speaking calls. When it gets a little complex, that's when I get squirmish and have to tap out and get someone to help us. But it's not very authentic when you have to talk to someone on a three-way call with an interpreter, and that can make you lose the trust of your patient sometimes. It's great we have those services, but again, that's a huge barrier when it's not face-to-face with your patient. Religious things can be a massive barrier, especially when we're thinking about blood type of disease states, when we're looking at cancers and if patients can receive blood transfusions and things like that, honoring people's wishes with that. I have a lot more, but looks like Rachel would love to chirp in.
Yes, Rachel, please chime in.
Thank you. Laura, you actually brought up a really good point. That was actually one of the significant barriers for myself. When I was going through my treatments, I actually lost the use of my voice. So I was not able to make phone calls or anything. And not a lot of specialty pharmacies have the ability to use the TTY systems, which is the text tone. So I didn't have a means to communicate at all. I had to go through a third party. I had to stay on the phone with my doctor. So a lot of the times our disabilities and our abilities are a huge impact and a huge barrier whenever it comes to getting these medications as well.
That's a really great point, Rachel. Jake, it looked like you wanted to chime in.
The overarching question is like, what are the barriers? And I think that when we consider the barriers around patients, access to care is one social determinant of health. But when we define the health inequities that we face, it is more than just our ability to get access. It's the food we eat or don't, the air that we breathe or can't, the places we live or don't live, the water that we can drink or not drink. But I think the best way to catch all of this is, again, related back to patients, the people that we're caring for. I love this story. The CHW technician was doing a patient visit. And so to Laura's point, they knew what unmarked house to go to. They didn't have to worry about FedEx finding it. Like, they knew where it was. They were there. They were in the patient's house and they were talking to the patient. And they were like, why aren't you taking your meds? I don't care what med it is, specialty or not. Why aren't you taking your med? And it was like, well, I got to buy dog food. So the choice was dog food, medications. And so they were choosing dog food, which fair, like good answer. No problem with that. So what does CHW do? Called Chewy's. Chewy's has a foundation that they will provide dog food for free. And so the CHW got dog food shipped to the patient's house for free. And now the patient is able to get access to their medications. And so I think the biggest aspect of this story that I would share is that when we think about health inequities, not to be pharmacy centric, not to be myopic on just pharmacy drug cost, but health inequities are the cost of the household and how that plays into getting the access to care.
Awesome. Yes. Amazing, Jake. Thank you. And, you know, that was a very innovative approach to overcoming a barrier, right? And so that leads into this next question that I wanted to make sure we spent some time on, which is, okay, so we know about all these barriers. There's the social determinants of health related barriers, and then just the barriers that are inherent to specialty medications. But what are some things that could be done to help overcome them, to help improve access for these patients who are on specialty medications? So Laura, I think I'll start with you, and then Patricia, I would love to hear your thoughts as well.
Yeah, so I think I'll start with the easy one, which is figuring out the cost of meds. So I know that doesn't sound easy, but that tends to be the one that us pharmacists find easy. That's our jobs. So looking at copay cards for patients, looking at grants, looking at, for me, serving people who live with HIV, the Ryan White Foundation, tapping into that, using lots of different funds out there. Maybe we have to go the free drug route. And, maybe we're the ones who are going to have to fill out that paperwork and be the owner of that and stay on top of the prescribers to get the signatures on that. So cost of the med and getting the access to that, that's one way. That's one potential barrier solving. Sometimes it's just, sometimes it's food. So where can you go when you're local? So some specialty pharmacies ship. Some are local. I'm lucky that mine's all like a local specialty. So I know what's going on. I know where things are happening. So we're able to say, hey, there's a food bank here that's open these days. Hey, there's a food bank here. Or, hey, I actually know a pharmacist who does insulin counseling and works at this food bank on these days. This will be great for you.
Love that. Thanks, Laura. Patricia, do you have anything to add?
Yeah, I would just say adherence calls also, it's something that is, a small thing, but it can make a big difference. Patients can just forget, they get busy. So making sure we're staying on top of our adherence calls, connecting patients with those CHWs when they need it. I've seen where they can get patient connected with local support groups, and that makes such a big difference in some patients' lives because of that loneliness that was mentioned earlier. So having that support group. And also some pharmacies can offer face-to-face consultation via a secure video. We ship nationwide. So our patients are not local a lot of the times, but we can offer a secure video if patient needs help with like injection training, they're not understanding something, troubleshooting their therapy and getting that injection done correctly.
Great tips. Meredy, do you have anything to add from the community pharmacy perspective?
Yeah, like Patricia was saying, I kind of like to call it like the peanut butter and jelly effect, stacking kind of the resources on top of that. Like she said, and even Laura mentioned, like the food bank on top of the other things. Where can you go to get this and top of this, and recommending places for transportation while you're building these relationships with your community.
Awesome. Great. And I just realized we've been saying CHW. And so for the audience who might not know, that acronym stands for Community Health Worker. We will expand on Community Health Worker shortly. So this question that we received, I think, is very important to address. So it's, how can we help patients who make too much money to qualify for patient assistance programs, but who cannot afford expensive specialty meds that they need to be on, even with insurance? Laura, if you can start, and then we can pass it on to others.
I'm not going to pretend to know the answer to that because that's hard. There are copay cards out there that can help. Unfortunately, copay cards can max out. Copay cards cannot go to a patient's deductible, which then doesn't help them in the long run. You may only be able to use a copay so many times. So while it's great, it could cause problems in the long run because you could get on a medicine, be on it for 3 to 4 months, and then your copay card runs out of money and you can no longer be on it. It's really hard because you can have great insurance and the drug can still be out of reach, out of pocket.
And then I don't know if Meredy, if you have any additional thoughts, or even Rachel, just from your own experience, but I'll just open the floor. Feel free to jump in.
Sure. You can look into state provider plans, and that's really where you should use your community health worker to look into different types of plans, like those kind of state provider assistance plans. And those aren't necessarily pharmaceutical plans. It could just be grant opportunities and things like that. And then other options are charities in your area, organizations. There's nonprofit pharmacies in the area. So it may or may not be your pharmacy filling it, but when it comes down to it, we're here to help that patient. So I know in Richmond, we have 2 or 3 different nonprofit pharmacies. And then there are some pharmacies that are able to take in donated with integrity medications that they're able to dispense. So you can always check in to see if somebody's eligible for those, to see if it's there. So, it stinks when somebody is just above the threshold that they don't qualify for different types of aid, but they still need the aid. So there's different options out there. Just, you kind of have to get creative.
Definitely. Yeah, great tips there. All right, well, we already kind of touched on social determinants of health. Thank you, Jake, for giving us an introduction to that. And you did mention that statistic that I do want to narrow in on, because I think it's very powerful in that 80% of health outcomes are due to social determinants of health, while 20% are due to medical intervention, which would be like the specialty medication, for example. Can you talk a little bit more about what that means?
Yeah. So in Richmond, Virginia, there are zip codes 5 miles apart, and the life expectancy difference is 20 years. So what's going on that the life expectancy is 20 years different within 5 miles of Richmond, Virginia? And it boils down to the social determinants of health. What if this was Palestine, Ohio, where there was a chemical spill from a train? What if this is Flint, Michigan? So why do we not live long and we're 5 miles apart? Because there's lead in my water, because my infrastructure is not producing clean water. That is more damaging to my health right now than if I were to develop diabetes as a Hispanic male over time. So that's where that 80% comes from.
But there are factors, right, that are considered to be social determinants of health that do kind of influence a patient's ability to access medications. And we already talked about how challenging it could be to access specialty medications. But if you can maybe talk a little bit more about that, Jake, about specifically how do social determinants of health influence a patient's ability to access medications in general?
So when we think about access, it is such a big, broad word, and it is the physical access of in my hand. It is access because of cost barriers. It is access because of cognitive barriers. We have a colleague and friend in Wisconsin, Milwaukee, and to Laura's point, his pharmacy, he has like 8 or 10 pharmacies, and they speak over 30 languages because they are designed to be in their communities, to understand the cultures. I'm a community health worker in Alabama. If I come work with, I know, Patricia, you're not in Bentonville. I'm going to act like you're in Bentonville. I don't know if you actually are. So I'm going to come over from Birmingham to Arkansas. And am I a community health worker? No, I'm just a worker because I don't know that community. The whole aspect of a community health worker, the whole aspect of addressing health inequities is understanding the community and the resources that those communities have.
I do want to follow up on something you said, Jake. You had mentioned about getting paid for pharmacy delivery services. Are you seeing a shift, or do you foresee a shift in that a payer would start to pay pharmacies for their delivery services?
So it's all about the business model. It's the ROI. And so can we justify a cost on a billing model so that we pay for local delivery? And the answer is kind of yes. But what's happening is that if you look at the 10K of your publicly traded pharmacies, you kind of look at what they're selling. And it's always prescription sales and OTC sales. And we lose money on 80% of our prescriptions at this point. They're loss leaders. We just lose money on 80% of our prescriptions. So that's out the window. OTCs, I can sell as many Legos and books as I want, but it's not going to offset those prescription sales, right? So we try to diversify our down front. Some pharmacies now report on a 10K perspective clinical services. Do I do diabetes self-management education? Point of care testing is more of a clinical service. And so we argue and train within our network of pharmacies to have a health equity service line. Put your expenses around health equity on that service line, but also track your revenue for health equity on that service line. And as a clinically integrated network, we're able to get network-wide contracts with payers. And so I sit in the room and I have those conversations, and we do get network-wide payment contracts for the services we render about the products that we dispense. And I think that vernacular that I'm using is very, very important because it's more than just the product, it is the service. And oftentimes that's through value expression, which is why we use a standardized quality measurement system at our pharmacies. The CPESN Health Equity Network, because we just got our recent report card, 85% of children have a documented wait in those pharmacies. So if I go to a Medicaid program and say, let me help you because our network treats patients differently, and they say how, I can express our value. We document the weight of a child at our store every single time so we know the dose is correct.
That's awesome. Those are great examples, Jake. And we keep mentioning the community health worker. And so I want to get some attention on what is all involved. So, one of the things that I keep hearing about pharmacies doing more and more is, in a way to help identify and address social determinants of health, are to get their staff trained to be a community health worker. And Meredy, I'm so glad you were able to join us today because I know you've gone through the training. And so I'm wondering, as someone who has gone through this training, can you spend some time explaining what a community health worker is and what your training entailed?
Your primary responsibility includes educating community members on health issues, promoting preventative care, assisting with accessing healthcare services and resources. So my training consisted of a 2-hour course weekly for 16 weeks. And then also I was involved in intense topic discussions during those 2 hours, completed patient case reviews. We built this intense community resource portfolio, intense. And then during the process, I also interacted with my community. So I went and shadowed in my community diverse resources and discovered more and more about opportunities available locally. The class itself covers core competencies, like you're going to learn health education, cultural competencies, advocacy skills. You learn empathy, which is really hard to learn, but you utilize it. You kind of like get in touch with yourself and really bring that out. It really includes practical training and conducting community assessments. It provides social support, navigating healthcare systems. CHWs really are playing a vital role in promoting health equity by addressing the barriers to healthcare and empowering communities. And we're going to improve health outcomes by doing this.
Awesome. If someone was interested in getting trained, what advice would you give them?
Really look into the courses that are available. There are really great ones out there. I was very specific into finding one that was pharmacy technician specific because of our healthcare background. That was really, really important to me. I wanted to make sure it was accredited for CHWs, and then I looked into the credentials that were specific to my state. I'm in Virginia, so after a certain amount of hours that you put into your community, you can actually go get credentials with the state of Virginia. And so different states have different credentials. So look into that too if you want to go pursue that after you finish your course. For me, it was important to find that program. Look into different community, the different information that's available. Research the role first and what it's going to mean in your role. What are you going to do with it? And how does it pertain to your current position? Are you going to be purely a CHW in your community? Because you can do that. Are you going to be that alone, a standalone? Or like Rachel, do you want to partner with being a pharmacy technician? For me, that's really what it was about, and helping our current community and our patient base that we have here. And then start networking in your area and talk about it with other people and let them know this exists and how important it can really help.
We hope you enjoyed and gained practical insights from listening into this discussion. Now that you've listened, pharmacists, pharmacy technicians, physicians, and nurses can receive CE credit. Just log into your pharmacist letter, pharmacy technician's letter, or Prescriber Insights account and look for the title of this podcast in the list of available CE courses. On those websites, you'll also be able to access and print out additional materials on this topic, like charts and other quick reference tools. If you're not yet a subscriber, find out more about our other product offerings at trchealthcare.com. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app. Or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Medication Talk.